Our speaker is Dr. Michael C. Caldwell. Dr. Caldwell is Associate Professor of the Department of Internal Medicine and the Department of Professional and Medical Education. Dr. Caldwell received his education, BA degree from Columbia University, MD degree from Mount Sinai School of Medicine, MPH from Harvard University. Dr. Caldwell is going to speak to us today on the subject of respiratory syncytial virus on the threshold of the first vaccine. So let's give our attention to Dr. Caldwell.
Thank you, Dr. Talley. It's a pleasure to be here for my first grand rounds at Meharry Medical College. I'd like to thank you and your team and the Continuing Medical Education Office. Thanks to Dr. Vladimir Berteau for helping me with putting this presentation together. And thank you all for welcoming me to Meharry Medical College, especially Dr. Fremont, Dr. Smoot, Dr. Ofodile, and of course, Dr. Hildreth. It's a pleasure to be here with you at Meharry and talking to you today about a really important respiratory virus that a lot of you know about, but probably a lot of the public is really only just starting to learn about, and that's respiratory syncytial virus, RSV. I often have heard it called the most common respiratory virus that you may have never heard of. So this presentation will cover these learning objectives. I'll be discussing the RSV history and epidemiology, the clinical presentation, some of the treatment options for RSV and prophylaxis for RSV. Just to note, there is no RSV vaccine right now, so I'm going to dive into the research as well as the hopes for the development of an RSV vaccine and what some of the local research we're doing right here with Meharry and partners. These are my disclosures. I am currently a clinical investigator on a number of different vaccine studies, and I was previously employed at the companies that you see listed here. What is respiratory syncytial virus? Well, it's a virus. It's a member of the paramyxovirus family. It's a single-stranded RNA virus. Now, some of the other single-stranded RNA viruses include para-influenza, mumps, measles vaccines. There are two major strains of RSV, strain A and strain B. And strain A is responsible for most of the morbidity and mortality of RSV in the United States. Please take a look carefully at this graph. You'll see this is a viral particle. The single-stranded RNA is in the center, and surrounding the virus are different colored graphics representing proteins. The purple one is the fusion protein, and the green one, the attachment protein G. So we have two major proteins, the F, the fusion protein in purple, and the attachment protein G. So what happens is that this viral particle is floating around, and it gets inside of us, and the G protein attaches to our epithelial cells in the nasal mucosa, and it kind of just stays there and cannot go into the cell unless this fusion protein is active. Now, the research to try to target RSV and develop vaccines and therapeutics and prophylaxes have very much been focused on this fusion protein, the F protein. RSV is something that was discovered only in 1956. It was initially discovered when a new virus was isolated from a group of 14 chimpanzees that were noted to be suffering from colds and coryza. So it was actually originally called the chimpanzee virus. It was later realized that the chimpanzees actually caught the infection from their caretakers. So RSV virus was named finally after there were isolates found in 2 children, one with laryngotracheobronchitis and the other with a bronchopneumonia. And this is the hallmark of some of the morbidity with RSV, LRTI, lower respiratory tract infection. That's what really causes a lot of the problems with this virus. So human antibodies were found in infants and children, revealing that this infection was very, very common in early life. And in cell culture, what was particularly of note is that there were these multinucleated cells known as syncytia, and that's really how it got its name, respiratory syncytial virus. Take a look here, and you'll see in the center there is an infected cell. And there the viral genome produces these viral fusion proteins. And that one infected cell can, if you look on the right, fuse the membranes with all the other cells nearby. And this is one of the very few viruses that do this. You may know that viruses typically infect a cell, reproduce copies of itself, and then sort of explode the cell, and those viral particles go out throughout your body. Well, here you have the development specifically of the coming together of these cell membranes, forming these giant multinucleated cells. Here is a specific photograph of the respiratory epithelial cells causing inflammation and edema. So these large masses of multinucleated cells are called syncytia. On the left is an electromicrograph of these RSV particles, and on the right is an H&E stain of a lung biopsy from somebody with RSV pneumonia, once again showing clearly these cytoplasmic inclusions. The CDC provides a lot of important information, and RSV is no exception. I encourage you to go to the website on the CDC website, focusing on RSV. Here is the RSV home, and there's a special section for healthcare providers, so that's updated regularly. You can review the epidemiology, the transmission prevention, people at high risk for RSV, and learn about some of the new research. Also, you will find this really important and timely website, which helps us to understand what is happening with RSV in our communities around the country at any particular time. This is the CDC's National Respiratory and Enteric Virus Surveillance System. It's also known as NERVIS, so it helps to inform the community and medical practitioners across the country about what is happening at any given time with all types of respiratory and enteric viruses. This particular slide is focused on RSV and what the RSV trends are. And if you go down into this website, the RSV surveillance is very, very important because RSV does appear at different times in different parts of our country. Usually the season of RSV is approximately about 5 months, usually overlaps the flu season in late fall to early spring. Although there can be times, especially in the southern part of the United States, where there's a much longer season. For example, Florida, oftentimes the RSV season starts earlier and ends later. RSV is not limited to the United States. It has a severe global impact. Even though it does impact us here in the U.S. and other high-income countries, it's the low-income countries that really suffer. There is a seasonality to this, overlapping flu usually between the late fall and early spring. And there are geographic differences between the northern and summer between the northern and summer. Let's try again. There are geographic differences between the northern and southern hemispheres. Same with flu. At the time that we are having our winter time, there are high rates of flu and respiratory diseases here in the northern hemisphere. And when we're having our summertime, well, down in Australia and other parts of the southern hemisphere, they're having their flu and RSV seasons. So there are these geographic differences. So in the United States, RSV causes approximately 2 million outpatient visits every year among children younger than 5 years old. Just think about that. That's quite a burden and something we don't hear much about. There are approximately 60,000 hospitalizations among children less than 5. And it is the number one cause of hospitalizations in children under the age of 1, RSV. RSV also affects the older population, even much more severely than infants. People over the age of 65, there are nearly 200,000 hospitalizations for people over 65 and approximately 14,000 deaths. This is a graph which shows RSV in the southern hemisphere, so you'll note that the seasonality is the reverse of what we see here in the United States. For example, you start seeing peaks from May to about November, and this is the opposite of what happens in the northern hemisphere. But I want to point out to you specifically is the variability between whether RSV-A or RSV-B is predominant. So this graph, looking at the years from 2012 to 2018, shows that pretty much predictably you can know that there's going to be RSV every year. But whether RSV-A or RSV-B is more predominant, we won't know until we start testing. Look at the differences between 2017 and 2018. You'll see in yellow, RSV-A is very low in 2017, and the green RSV-B is very high. Remember, RSV-A does cause more of the morbidity and mortality with RSV. So you would think that 2017, although there was a predominance of RSV, maybe it wasn't as bad symptomatically as 2018, because in 2018, you'll see that there was a predominance of RSV-A rather than RSV-B. What's happened since 2020, the years of COVID, there was a near complete suppression of RSV in 2019, 2020, as well as the beginning of the 2020 to 2021 season for both RSV and flu. There was a major resurgence of RSV in the spring of summer of 2021. And remember, we normally see RSV and flu in the wintertime, not in the summer. So something very unusual happened in 2021. Respiratory syncytial virus infects almost everybody by age 3. Let's take a look here, and we'll see those who are under 1 year of age. About 2/3 of children, by the time they hit their first birthday, will have had exposure or had RSV. And about a third of those, 21% total, have lower respiratory tract infections. Now that's the symptoms that can cause some real severe problems and result in hospitalizations, NICU, and ventilators and death. If you look up to age 3, you'll see that nearly 100% of children are exposed to RSV, but only about 6% have lower respiratory tract infections. So whether this is immunity building up, the children's immune system is getting stronger, their bodies are getting bigger and stronger, and they can deal with a lower respiratory tract infection better than when they were just so young and their bodies are so small. How is RSV transmitted? It can be spread similar to the way flu or COVID is spread. Whenever an infected person sneezes or coughs, these respiratory droplets are transmitted. You can spread it through your eyes as well as your nasal secretions or your mouth, as well as if you touch your mouth and then touch a surface to contaminate that surface. Those surfaces are called fomites, and when those surfaces are contaminated, they may stay contaminated for a number of hours. So if somebody else comes by, even though someone is not in the room, they could touch that infected surface and then touch their eyes, their nose, their mouth, and infect themselves. And we often touch our face multiple times a day. We don't even realize it, and we're continually putting ourselves at risk. So RSV is contagious even before people get symptoms. The symptoms can occur usually and last for about 3 to 8 days. And people are often exposed to RSV outside the home, usually in school settings, child care centers, and it's very commonly transmitted. So people at any age can get RSV, and the natural infection doesn't confer lifetime immunity. And those who are at highest risk are premature infants, children with congenital heart or lung disease, children with compromised or weakened immune systems, and adults, anyone over the age of 65, people with compromised immune systems, or anyone with underlying heart or lung disease. The symptoms of RSV are shown here. Most develop an upper respiratory tract infection, cough, low-grade fever, sore throat, runny nose, nasal congestion, or headache. But those up to 40% who develop a lower respiratory tract infection can be in some trouble. They can get tightness and chest pain, wheezing, and could really be suffering and need hospital care, intensive care unit, and ventilatory support, and also puts them at risk of dying. So also here, most people will recover between 1 and 2 weeks. This is a scary looking photo, but something that pediatricians see. This is very dangerous when a child walks in with this presentation. You'll see here nasal flaring, hypoxemia and cyanosis, the chest wall retractions, expiratory wheezing, prolonged expiration, rales and rhonchi, and tachypnea, with most concerning apneic episodes. So this is a medical emergency and needs to be addressed immediately. Severe RSV disease is hallmarked with hypoxia, cyanosis, and this extreme respiratory distress and respiratory failure. Severe RSV disease is the leading cause of hospitalization in infants less than 1 year of age. And both RSV bronchiolitis and bronchiolitis of undetermined nature are thought to be the most common diagnoses of infants under the age of 1. Other common admissions are pneumonia, jaundice, and dehydration. But just look at that, the burden of this disease in our community and in our young babies. It's another way to look at it, this pie graph, to show that at least under the age of 5, over 2/3 of cases of respiratory virus are the RSV. Some of the other ones are listed there for you on the left, but this is a study that shows again that RSV is a major, major burden of disease throughout the world. Now that we have experience with COVID and flu and also RSV, all of these can happen at the same time. And you're probably wondering, can I tell the difference between if somebody presents, whether they have flu or COVID or RSV? Quick answer is no, anybody can present with just about any of these symptoms, and it could be anything. So testing is so important, and you can test all 3 of these at the patient's bedside and get an answer very quickly to help you determine which one of these it is, so also can help you with your treatment and therapy. But let's try to take a look to see what differences there may be. So flu, we know, is dangerous in both infants and the elderly, although it seems to be more dangerous in the elderly. There's a 1 to 4 day incubation period, and people can be contagious for 1 day prior up to 7 days after symptoms start. COVID is most dangerous in the elderly also. It can also be a problem with children, and we're learning more about this as the COVID pandemic evolves. Usually, people are able to transmit COVID about 1 to 3 days before they have any symptoms. With RSV, it is most dangerous with infants, but also with older adults too. But we think mostly with RSV as a problem with infants. And you could see there the incubation periods and the contagious periods. So I want to bring to your attention that there is no vaccine for RSV right now. There is vaccines for flu. There is vaccines for COVID. But there's a lot of research for vaccines for RSV. We just haven't found it yet. There is something called prophylaxis for RSV, where we give children a monoclonal antibody, not after they've been sick, but before they get sick, children who have high risk of RSV, and we give it to them once a month during the RSV flu season, usually starting around October or November. And this is determined by the number of cases of RSV that we see in the community at that particular time. All respiratory viruses, including RSV, worsen people who have chronic health conditions. So if anybody has any other chronic health condition, RSV is absolutely going to worsen it. How do we test for RSV? Well, we can get both upper and lower respiratory specimens. And RSV has not previously been tested as well as it is now. There's a new type of test, multiplex PCR assays, which test all three common respiratory viruses, RSV, COVID, and flu A and flu B. So we can do it right here at Meharry, where we do this point of care testing to be able to know what somebody has so that we can take the appropriate measures to treat them. These new tests are very sensitive and very specific. So what's the treatment of RSV? Well, for most people, RSV has no treatment. It goes away in a week or two. And there is no specific treatment. It's really just supportive. We treat these the way we treat most common respiratory viruses that don't cause too much trouble. Medicines for pain or fever, keeping hydrated, resting, and seeking extra supportive care in the hospital for severe cases. I want to talk to you for a moment about something called prophylaxis. Prophylaxis is this particular FDA-approved monoclonal antibody. It's called palivizumab. The drug name also that is used is called Synagis, so you may know it by either palivizumab or Synagis. It was approved in 1998 by the FDA specifically to reduce hospitalizations in infants, high-risk infants who were premature gestational age below 36 weeks. There is not a mortality indication for this palivizumab, so the studies that they did not demonstrate specifically a reduction in mortality. However, it did specifically have a reduction in hospitalizations. Now, that's really important because if you can reduce children's hospitalizations, you're going to reduce their being in the NICU, being on a ventilator, and all of those have long-term, lifetime complicating factors which can impact these infants as they age and become adults. The pivotal paper which demonstrated that Synagis or palivizumab worked is called the IMPACT study. Once again, only showed a reduction in hospitalizations. I think that even though it did not show a reduction in mortality, I would believe that there probably has been a reduction in mortality. It just wasn't able to be measured in this study. The American Academy of Pediatrics has the Committee on Infectious Diseases. They put out something called the Red Book. And in 2003, they had looked back at some of the uses for palivizumab. And they decided that they would limit who would have access to this based on their recommendations to children who are much even younger prematurely. The usual gestational age is about 39 or 40 weeks for a full pregnancy. So this palivizumab was previously or initially and still is approved for infants 35 weeks gestational age or younger. However, in 2003, this technical work group believed that the immunoprophylaxis should only be used on infants who are even younger than that. And they put out this policy statement here, the updated guidance for palivizumab prophylaxis among infants and young children at increased risk of hospitalization for respiratory syncytial virus. And they specifically decided that it was not useful to use palivizumab in these young infants. They said it wasn't cost effective. Now, I have a real concern about this because the majority of premature infants tend to be from lower socioeconomic communities, specifically African Americans. So when you have a greater pool of children who are from lower socioeconomic backgrounds and a greater pool of African Americans and Hispanics, you're selectively putting more of these children at risk by reducing the availability of this medicine to those populations. I think that this is an example of a misguided change in the recommendations, which did not take into account health equity. So we had the FDA approval, the COID AAP decision reduced the recommended use of this prophylaxis below 35 weeks down to 29 weeks gestational age. So there was a loss of about 80% access of infants that previously had this. So this decision was made completely without regard to those specific communities that were going to be most harmed by this decision. It was felt like, oh, well, maybe this medicine really doesn't make that much of a difference, doesn't work that much better to reduce hospitalizations. But it does. It does reduce hospitalizations. And what is the alternative? The alternative is to do nothing. I had the opportunity to travel the country and meet a lot of neonatal doctors and other nurses and medical providers that took care of infants who were premature. And they could get access to palivizumab even if they were over 29 weeks gestational age, but they had to fight with the insurance companies. And that is specifically due to this recommendation by the American Academy of Pediatrics, which limited now this prophylactic medicine from these infants. And I saw in the eyes of the NICU medical providers how concerned they were, working so hard to save these premature infants and knowing that they would have to send them home without this added extra protection of this palivizumab during the RSV season, or they were not able to get access to it, or the families couldn't afford the copay because of this recommendation. So I saw real harm and real concern from these recommendations. And there is no other alternative right now. There's a lot of research going on to try to come up with newer prophylactic medicines, newer RSV vaccines. But as of today, children are not getting access to this only prophylactic therapy, and there is no alternative. The alternative is prayer and hope that the child will be okay. And that doesn't always happen. So this did not go unnoticed. The National Medical Association, which is the Association of African American Physicians, spoke up and said that they were concerned that this decision by the American Academy of Pediatrics, the Committee on Infectious Diseases, was not taking into account the harm that this decision made on the young, premature babies of African American descent. They specifically showed that the majority of premature infants, or there is a much larger percentage of prematurity in the African American population, and therefore this decision targeted them. And the National Medical Association asked that this be addressed. So Now look, in 2010 and in 2013, they brought this to the attention of the American Academy of Pediatrics, and they still have not heard back. Well, let's switch to some of the progress that we've made with RSV vaccines. And this started back in 1966, sort of the golden age of when a lot of vaccines were being developed. There was a formalin inactivated vaccine, and there was a problem. The children who were in the study, who got the vaccine, after they got RSV, it didn't protect them. It actually made the disease worse. So 2 children who were in the vaccine arm actually died because of having the vaccine. So this stopped in its tracks RSV vaccine research, because there clearly was something that wasn't quite understood. And now there's been a lot of new developments, and there was a thought that had there been added an adjuvant to the vaccine, or we were able to do something new to how to stabilize the fusion protein, perhaps we'd be able to make some progress. So what really happened in 1966 with this initial vaccine study is still being debated. Well, you might recognize this person here. That's Dr. Barney Graham. He's originally from Vanderbilt, Nashville. He is the deputy director of the Vaccine Research Center at the National Institutes of AIDS and Infectious Diseases at the NIH. And he and his team worked very hard to understand the structure of RSV and how that could be manipulated to be able to improve vaccine development. And his work on the understanding of the virus of RSV directly correlated with our ability to make the COVID vaccines and make them as successful as they are and have been. This gives us great hope that the technology for having a successful COVID vaccine will lead now to a successful RSV vaccine very, very soon. So the NIAID Vaccine Research Center does a number of different things. They were created with the intent to develop a vaccine for AIDS. Now, while they haven't achieved that goal yet, they are doing a lot of work with a lot of other different viruses to understand their structure, and they work all over the world, and they're doing a lot of really important work, and we're really lucky that we have had them, because all the work they've done has positioned us to be able to address this COVID pandemic, and without the work that they have done, we would not have been able to so quickly create a COVID vaccine the way we have. And it comes down to this, that F protein, which I showed you earlier in our presentation, the respiratory syncytial virus fusion protein. It turns out that this fusion protein is not stable. It changes shapes. As the virus enters our body, it looks like this. Pre-fusion F structure. So before it fuses with your cells, it looks one way. And then once it enters our cells, it turns into a post-fusion structure. And this was thought to be the reason why the RSV vaccine research in 1966 may have failed, because they thought that that vaccine was developed focused more on the post-fusion version of this. So it wasn't until about 2014 that we even knew there was a fusion and post-fusion configuration of this F protein. So let's take a look at this for a moment. You could see that the difference between the neutralizing antibodies that you can make from a vaccine developed if you are able to stabilize this structure, this pre-fusion structure. It completely changes the way this potential vaccine research could work. On the left, you'll see the blue dots that are neutralizing antibodies from a research which focused on a post-fusion vaccine. But on the right, you'll see what a difference that makes, an increase in 14-fold of neutralizing antibodies against the pre-fusion F structure. And this is felt to open the door for us now to have a successful vaccine. So the antigenic site for the vaccine is at its apex. It's that red area. And it turns out to really have this high neutralizing sensitivity. The class 1 fusion protein is analogous to the COVID spike protein. So because of this research of Dr. Graham and being able to find a way to stabilize this pre-fusion structure, they did the same thing with COVID and the spike protein. And were they not able to do that, we would probably not have such a successful vaccine. So this research in stabilizing the RSV pre-fusion structure directly correlated to our ability to create the vaccine for COVID. And Dr. Graham makes this clear in every presentation that he gives, that were it not for this research on RSV and the real detailed understanding of these proteins and how they change conformation as they go from outside the body to inside the body to inside the cells, that we would not be able to create vaccines that are targeted appropriately. A lot of work is going on now to create a vaccine for pregnant moms. If this is successful for RSV, it will be the very first time that there would be an FDA indication for a vaccine for pregnant moms. Now, there are other vaccines which we do use now and give to pregnant mothers, flu, pertussis, COVID, and we know that these have been shown to be safe, but they have not been done in a way before the vaccines were licensed so that the FDA would approve it. So CDC recommends the COVID vaccine, the flu vaccine, the pertussis vaccine in pregnant moms, not only to protect the mom, but that the antibodies, the passive antibodies, will protect the fetus, and that they, when they're born, will be protected, because those antibodies will continue for some short period of time until the baby is able to start building up their own immunity. So this is one of the strategies that are being employed with a new vaccine that is being researched, where they are including pregnant moms and vaccinating them with this this research vaccine for RSV. And we're really excited that this might really help reduce the morbidity and mortality of RSV in these premature infants, which is such a big concern. So we are starting to see a plan of action develop where we're going to be able to attack RSV at different places. Hopefully, the maternal vaccine will work and will vaccinate all pregnant moms with this vaccine. This will protect both the mom and the baby. We are also in the process of developing improved monoclonal antibodies for longer acting, which won't be just what we saw earlier with palivizumab and Synagis, given to babies who are premature and high risk, but something that we can give to all babies very young, these monoclonal antibodies, long-lasting, so that they will be able to get through their first months and year of life. Until then, we can give an additional RSV vaccine to them when they're a little older. I'm focused on right now clinical research for the RSV vaccine for older adults. There are 2 studies ongoing right here in Nashville where we're recruiting people age 60 and older to test 2 different clinical research vaccines for RSV. And there's a lot of real encouragement and excitement to know that these vaccines have a high degree of likelihood of being successful. This provides you an overview of what we think is going on with RSV research. If you look on the far left, you'll see all the different types of vaccines and monoclonal antibodies that are being studied: live attenuated, protein-based, nucleic acid, recombinant vectors, and immunoprophylaxis. What stages they're at, whether they're in preclinical, phase 1, phase 2, phase 3, or market approved. Now, there's only one market approved prophylactic monoclonal antibody, which we talked about before, which is Synagis, but a lot of work in vaccines. GlaxoSmithKline, Pfizer, Janssen all have vaccines in development right now. This is something that you can find online at an organization called PATH, and they update it pretty regularly. So some of the candidate RSV research vaccines are listed here. Moderna has an mRNA vaccine. Janssen has a vaccine with an adenovirus and a protein similar to the vaccine that they have for COVID. Pfizer has a bivalent protein vaccine. Remember, there's both RSV-A and RSV-B, so their vaccine targets both of those. GSK is focused on the maternal immunization, and they have a protein plus an adjuvant. This adjuvant is the same adjuvant that was used in the new successful shingles vaccine that came out in 2018. And Sanofi and AstraZeneca are working on this longer-acting monoclonal antibody prophylaxis, which might be able to be used on all infants. I am so happy, grateful, and excited that Dr. Hildreth asked me to help pilot and lead the pivotal partnership between Meharry and Clinical Research Associates, which is a clinical research organization here in Nashville. They've been around for over 30 years, and they have done a lot of clinical research on a lot of different therapeutic areas, but they've really had an expertise in vaccines recently. And one of the things we're both working on is the pediatric COVID vaccine right now. Clinical Research Associates is recruiting for the Pfizer vaccine, and Meharry is recruiting for the Moderna vaccine. Please go to this website here to learn more about this partnership, and we're still looking for children ages 6 months to 5 years of age. We're also looking for adults over age 60 for the RSV vaccine. So we are determined to expand education into the community, to be able to let more people know the importance of clinical research, that we need people to volunteer. We need people from different parts of our community to volunteer because we need diversity. So we are committed together to educating the community to try and identify more people to be recruited for these studies, and to have people and families feel a real sense of purpose and connectedness, that they're really making a difference. And there's no question people in Nashville have been offered this opportunity, and they're stepping up. Thousands and thousands of people in Nashville are part of these studies and are helping us to be able to help the United States and the world by knowing which of these vaccines are doing what we hope them to do, and as well as very closely identifying whether there are any side effects that we should be concerned about. So this partnership is expanding. We right now also are recruiting for people over the age of 60 for these 2 adult RSV vaccines. And I'm very pleased to let you know that Dr. Hildreth himself is very open and public and wants everyone to know that he is also a volunteer in this study. So this is just the beginning of a great partnership and arrangement between CRA and Meharry. We are going to be incorporating more education and medical student training, and we look forward to bringing on a lot more research very soon. There's been some recent news about our recruitment for this RSV vaccine, and it's listed here. So if you'd like to know more information, just click on those links. It's very easy to sign up. All you have to do is go to the website here, put down some information, and someone will follow up with you. So it would be important whether you, if you're over age 60 or know someone there is, your patients really appreciate you being aware of this and helping us achieve our recruitment goals. And I will definitely keep you informed of how our research is going, and anytime that I can give you updates, I sure will. Well, that brings us to the end of the presentation of respiratory syncytial virus, the most common respiratory virus that you may never have heard of. So thank you so much, Dr. Talley, and all of you colleagues at Meharry Medical College. I look forward to working with you and provide you another update real soon. Thank you.
Thank you, Dr. Caldwell.
Any questions for Dr. Caldwell? Any questions? Well, let me ask a question if nobody else has a question. So Dr. Caldwell, you mentioned that the difficulty it is for making vaccines, and we still don't have an HIV vaccine. That conformational change that you talked about on the fusion protein on RSV, does that occur on any other viruses or anything similar to that you know of?
Well, yes. Yeah, and we believe that is what has happened with the COVID vaccine. They were able to stabilize the conformation in the sort of for the COVID vaccine, the spike protein. They were able to stabilize that in the pre-fusion state so that you can get sort of the immune system a better view of what that protein looks like when the virus enters the body. So we have our immune system ready to attack the virus as it looks. So we think it happens in a lot of different viruses. And I will be able to just go back here to show you the slide, I think that most speaks to that. And I think it is this one here, where you can see that the success that we have had in being able to stabilize the RSV prefusion has now helped us specifically with the COVID vaccine and these other vaccines moving forward. So the specific epitopes that we're able to have our vaccines modeled after will be these newer epitopes you see listed here or noted here in red. that are going to be most likely to be successful for having neutralizing antibodies. And this particular slide shows that until we were able to get this pre-fusion conformation stabilized, we were not able to see or understand these little red epitopes. Once we were able to see them and be able to develop vaccines for them, the neutralizing antibodies there are 14-fold higher than what we were doing and where we were failing on the left with just the post-fusion. So it's made a tremendous difference. And yes, we are hoping that this will give us more clues to being successful with the HIV vaccine.
Thank you very much. Any other questions?
Yes, Winston Greiner. I have a question regarding the variants and how the pre-fusion F structure is affected by the variants and how we can computationally predict the kinds of variant and then have prepared pipeline appropriate vaccination initiatives.
Really important question, especially with our recent experience with COVID. I think it's too early to know yet. I do not specifically know that. I know that there is the RSVA and RSVB, which are essentially two types of viruses, but how these epitopes that we're targeting might shift, and will there be differences in subtypes or variants like COVID? I just don't know yet. I think that will be something for us to figure out, especially once the new vaccines come out and we start vaccinating people and see how things shift after there is a new vaccine. I really appreciate that question. It looks like we're going to have a lot to talk about down the road.
Are we seeing shifts in people who have received the vaccine for RSV already and in longitudinal studies and follow-up?
Well, thank you for saying that. I do want to clarify, there is no licensed vaccine for RSV. It's only in the studies right now. They're only in phase 3 studies, some in phase 1 or 2. So we don't have a vaccine for RSV, but we do hope to get one soon. We are recruiting for people 60 years of age and older here in Nashville for the older adult study of both the Pfizer and the Janssen vaccine.
Okay, thank you.
And thank you.
Any other questions? So let me give you the EADS code for this lecture. The EADS code is 96LENS, small letters. The number 96 and LENS. That is the EADS code for this lecture to get credit.
For those who are joining us for the first time, if you go to EEDS.com, that's EEDS.com, and put in that code 96LENS, it will take you to the evaluation. Complete the evaluation, and you will receive the your CME certificate, and you should print that off so you will have your copy of it. Thank you very much.
Okay, thank you, Dr. Caldwell, and we will conclude this grand rounds. Thank you very much.